with her. We were very excited when she went off to do her sports medicine fellowship. And we were even more excited to be able to recruit her back here to Rush, where she is currently an assistant professor of pediatrics in the Department of Pediatrics. And she is practicing general pediatrics as well as sports medicine. And so we're very excited to have her here today to talk to us about the pre-participation physical evaluation of children as they come to you with their requests to fill out school forms for sports participation. And I know we all sometimes have questions about those forms, and she's here to clear everything up. Welcome, Liz.
Thanks for having me. So today we're going to be talking about the benefits and burdens of pre-participation physical evaluations. I have no financial interest to disclose. The educational objectives of today are to recognize the importance of the pre-participation physical evaluation, also known as the PPE, in promoting safe athletic participation, appreciate the PPE's limitations in preventing sport-related morbidity and mortality, understand the burden of the PPE on patients, providers, and schools, and acknowledge the inequalities that exist in getting a PPE and the implications of not being able to obtain one. So about 60 million children and adolescents in the US participate in some form of sports, and about 80 million participate in organized high school sports. Sports physicals are required by 50 states prior to high school sports participation, and also by the NCAA prior to college sports. So that's millions of sports physicals that need to be completed annually. As pediatric healthcare providers, we should be knowledgeable about the current recommendations and controversies regarding these evaluations. So what is the PPE? Just letting you know, the term pre-participation physical evaluation is often used interchangeably with sports physical. Overall goal is to determine young athletes' medical eligibility, with the primary objective of maximizing safe participation in athletics. It can be completed in an individual office-based setting, such as within the medical home or in acute care, or in a group or station-based setting, such as in a high school. However, it is best completed in the medical home with a provider who knows the athlete as well as their medical and injury history. Additionally, it should ideally be completed about 6 weeks prior to the first practice in order to provide ample time for any further evaluation or rehab that might be required for full medical eligibility. So overall, it provides the medical background on which the physical activity decisions are made by the primary physician or a team physician and any associated medical staff, which could include athletic trainers, physical therapists, coaches, athletic directors, etc. And the findings are used as part of a healthcare program that focuses on prevention, assessment, treatment, and rehab of injuries and illnesses. So the overall goals of the PPE are to determine the athlete's general physical and psychological health, evaluate for conditions that may predispose athletes to injury or illness, as well as those that may be life-threatening or disabling, provide an opportunity for the discussion of health and lifestyle issues, and to serve as an entry point into the healthcare system for adolescents, especially those that lack a medical home. So it's not meant to be a replacement for the health supervision visit. It doesn't address long-term health concerns, immunizations, risky behavior, etc., especially when it's completed outside of the medical home. It's also not very highly evidence-based, and there's a lack of data that actually demonstrates its effectiveness. It's also not standardized. Requirements vary widely by state and by different organizations. There's significant variation between how providers complete the physicals. So just briefly, in the 1960s, the American Medical Association called for youth athlete screenings, and this led to the initiation of the pre-participation physical evaluation process for young US athletes. In 1992, the PPE Pre-Participation Physical Evaluation Monograph, first edition, was published, and this was developed by 5 leading medical organizations. And so for the past several decades, this has been the primary guiding resource for sports physicals. Most recently, in 2019, the 5th edition of this monograph was published with the intent of providing state-of-the-art practical and effective evaluation tool for physicians who perform these PPEs for athletes in middle school, high school, and college. This also was an attempt to try to standardize the previously not standardized process of completing PPEs. A little bit more about this 5th edition. So it really tries to describe the standard of care and provides a standardized approach to completing the PPE. It offers publicly available forms for providers, and these forms have actually been adopted by CPS and are recommended by the AAP for use. It reflects a rigorous attempt by the writing group to identify and outline evidence-based and expert opinion principles and practices in the examination and medical eligibility decision. So the components of the PPE, there's the history, physical, and medical eligibility. The history is by far the most important part of the evaluation, and it's more sensitive for detecting abnormalities than the physical. It can detect up to 88% of the medical and 67 to 75% of the musculoskeletal conditions that are found during this evaluation. Parent and athlete involvement together is essential, and when done separately, there's less than a 40% correlation between the athlete and parental reports. Athletes often do not know their family history and might not be aware of some cardiac history, and parents are often unaware of athlete symptoms. So here's a picture of the PPE 5th edition's history form that's recommended. Of note, it asks for the specific sport that the athlete is planning to participate in. And this also includes a brief mental health screen that includes 2 questions regarding anxiety screening and 2 for depression screening using this PHQ-4. One of the most important questions it asks is, has the provider ever denied or restricted performance or participation in sports previously? Because this can lead for a platform for discussing why that patient was previously disqualified or limited in their sports, and maybe provide guidance on what sports they can do later, or provide for further restrictions. So with the physical, it's important to start with the vitals, vision screening, and growth chart review. One benefit of doing this in the medical home is that you have access to that growth chart, whereas if you're doing it somewhere else, you might not have access to this. The exam should build on information that was found in the history. So if someone reported a specific musculoskeletal injury, then the exam can build on that finding. Poor visual acuity and elevated blood pressure are the 2 most common abnormalities. And really, the physical does emphasize cardiac and musculoskeletal systems. So here's what the physical form looks like from the PPE 5th edition. The last component is the medical eligibility. This depends on the history, exam findings, and the activity in which the athlete desires to participate. It's important to defer the decision until all necessary data has been obtained and the evaluations have been completed. When deciding someone's medical eligibility, you should really consider the pros and cons of restricting their eligibility for any reason. There's a huge emotional and physical impact of restricting eligibility, but there's also the risk of illness or injury if they should not be participating in the sport. If restricting an activity or deferring the decision for any reason, you can also consider alternative sports or activities. So if you're not clearing someone for football, they might be able to still golf or bowl or do some non-contact sport or something that places less cardiac demand on the heart. So this study this study by Carrick et al. Shows that only about 0.2 to 2.6% of student athletes actually fail the PPE, and up to 13.5 pass with some condition, such as limiting the sports that they can do or requiring further evaluation before full medical eligibility. Here's the medical eligibility form, and as you can see, someone can be medically eligible for all sports without restrictions, all the way down to not medically eligible for any sport. But there's also several categories in between there that someone can be cleared. Just of note, it's really important to stay consistent throughout forms. So if you are going to be restricting someone's medical eligibility, you need to also put this on the school form. Oftentimes when we complete these forms, we often just check full participation, and that adds to a lot of confusion. And if you really do feel like someone should be limited in their participation, then you should really be putting that on their school form as well. So the benefits of the PPE. First, it evaluates for life-threatening or disabling conditions during sports participation. Second, it's an entry point into the healthcare system for adolescents. And third, it provides an opportunity to promote physical activity and education on sports-related topics. For this first benefit, evaluating for life-threatening or disabling conditions, there's a major focus on the cardiovascular and musculoskeletal systems. In this 2019 study, they surveyed members of the Illinois chapter of the AAP and found that during sports physicals, there are specific topics, mostly related to cardiac and injury history, including concussion history, that are usually not asked about during the well visit. So when we think about the PPEs, one of the main things is trying to prevent sudden cardiac death. Cardiac disease is a leading cause of death in the US athletes. And the risk of sudden cardiac death is greater in athletes than the general population, usually due to the increased demand placed on the heart during physical exertion. The US incidence of sudden cardiac death is about 1 in 80,000 in high school athletes and 1 in 50,000 in college athletes. Sudden cardiac death, although the risk is relatively low, has a devastating impact on families, communities, physicians, and it attracts considerable media attention. Usually sudden cardiac death is due to an underlying and usually unsuspected cardiovascular disease. One study published in 2009 looked at sudden deaths in young competitive athletes over almost 3 decades. There were about 1,800 athlete deaths over the study period, and 1,049 of those deaths were attributed to cardiovascular causes. 80% of the cardiovascular deaths occurred during or just after physical exertion. Hypertrophic cardiomyopathy and coronary artery anomalies were 2 of the leading diagnoses found to cause the sudden cardiac death. So there is debate over the most effective and practical strategies for cardiovascular screening. Currently, EKGs are not recommended as part of routine sports physicals and routine screening. The American Heart Association 14-element screening checklist, which was developed as a joint effort by the AHA and American College of Cardiology, is currently endorsed for use by the PPE 5th edition. Any positive findings during this screening checklist require follow-up questions or further evaluation, and often do require an EKG. So this is that 14-point screening evaluation that screens for congenital and structural heart disease using personal history, family history, and physical exam. So next, we often think of musculoskeletal injury as a reason for doing these PPEs for trying to prevent injury. The MSK portion of the PPE is a leading cause for disqualification in sports. Athletic participation puts individuals at risk for acute musculoskeletal injury. And the strongest independent predictor of sports injuries is usually previous injury. If there are partially or inadequately managed or rehabbed injuries, it may result in more time lost from sport, increased risk of persistent injury or re-injury. The history and the brief orthopedic exam are generally used to screen for musculoskeletal concerns. However, the type and extent of the exam is determined by the evaluating provider, and it's usually based on any positive findings from the history, as well as time allowed. A general screening exam is usually reasonable for an asymptomatic athlete with no previous injury. The general screening exam may reveal undetected range of motion deficits or pain in athletes, especially if they're trying to avoid restriction by not putting anything down in the history. So this is the general musculoskeletal screening exam as recommended by the PPE 5th edition. It's a 13-point exam that rapidly assesses for range of motion, muscle asymmetry, muscle strength, and identifying significant injuries. So of note, the duck walk has now been replaced by a double and single leg squat test, and also a box drop test, which is also known as the vertical jump maneuver, and a step drop test to assess functional movement deficits. And these can be added onto that general medical screening exam if there's someone who's going to participate in a sport that requires a lot of functional movement, or that you just want to evaluate more. So the second benefit of the PPE is that it's an entry point into the healthcare system for adolescents. This might be an adolescent's only contact with a medical provider for the entire year. IHSA, or the Illinois High School Association, requires annual physicals. But interestingly, CPS only requires school physicals upon entering 9th grade or the CPS system. So that means there could be several non-athletes and non-student athletes that could go several years without ever actually requiring any sort of physical. And it might be the only opportunity for preventative healthcare and talking about wellness aspects of their only 1 in 15 adolescent visits to a healthcare provider are actually for preventative visits. If this is completed within the medical home, it facilitates general health care, immunizations, talking about risky behavior, and all the other things that we can do during a well child check. If it's completed outside of the medical home, any abnormal findings may prompt follow-up with the appropriate providers, or it could encourage that student athlete to establish with the primary care provider. The third benefit is that it provides an opportunity to promote physical activity and provide education on sports-related topics. So by offering a PPE during all well visits, it can be a platform for discussing the importance of physical activity and the benefits of organized sports. Questions on the history section can prompt education on those topics. For example, if it's asking, have you ever had a concussion, and going over that, you can use that to discuss what a concussion is and the importance of sitting out if a concussion is sustained. There's a question on the history form that asks, has anyone ever told you to lose or gain weight, or have you ever wanted to gain or lose weight? So you can use this question to discuss healthy strategies for weight loss or gain, especially in sports such as wrestling, where athletes might be trying to lose weight very rapidly. You can also talk about the benefits of supplements and the risks of those as well. So for someone trying to gain weight, they might be wanting to use creatine, so you can talk about how to safely use that. It's also an opportunity to propose safe activities. So if for any reason an athlete is scared to participate in athletics, or they don't know what sport to participate in, you can discuss all of the options with them. There are several limitations of the PPE, however. Overall, it has a very low sensitivity and high false positive rate when it comes to the cardiac screening. This means several athletes require unnecessary additional cardiac evaluation, which can be costly, time-consuming, and add psychological stress to the athlete and his or her family. Additionally, cardiac screening does not identify all athletes with cardiac disease or with risk factors for sudden cardiac disease. So in this study evaluating the performance of the 14-point evaluation versus EKG, 3,620 student athletes were screened for sudden cardiac death risk factors using the 14-point evaluation and EKGs. 55% of the student athletes had a positive screen, with the majority having a positive history screen. However, after physician review of the history, only 814 of those student athletes actually had a clinically relevant history. All student athletes with the positive screen then went on to have an echo. In total, though, only 16 of the student athletes screened had a major cardiac condition associated with sudden death. This study also found that the 14-point evaluation was only abnormal in 7 out of the 16 cases, suggesting that it does not pick up on over half of the student athletes with a major cardiac condition. This figure just shows that overall, that AHA 14-point evaluation has a sensitivity of only 18.8% and a specificity of only 75%, with a low positive predictive value. Malhotra and al. Conducted a study with 11,168 adolescent athletes in the English Football Association who participated in a cardiac screening program, which consisted of a health questionnaire, physical exam, EKG, and echo. Most of the athletes had a negative screen. However, 6 of these athletes still ended up dying from sudden cardiac death. So this study demonstrated that even with a very comprehensive evaluation, you cannot fully eliminate sudden cardiac death in all athletes. In regards to the musculoskeletal screening, there's no evidence that the MSK portion of the PPE is effective at accurately identifying or preventing at-risk athletes from injury. The general screening exam, which is recommended by the PPE 5, only has a sensitivity of about 50%. There's also no evidence that interventions in at-risk populations leads to decreased musculoskeletal injuries. There's a lot of variability in the musculoskeletal screening and how providers will complete this. It's also been found that some providers don't use an orthopedic exam at all as part of their screening and just use the history. Lastly, there's a lack of provider comfort with and knowledge of the musculoskeletal system in general, and this oftentimes leads to increased restrictions because of no knowledge of what can actually safely be cleared to participate. So despite that sensitivity of only 50% on the musculoskeletal exam, Over half of participants that were surveyed in this study said that they were satisfied with the MSK screening exam to find current injury, and a large amount were also satisfied that it would pick up for future injury. This study also just shows the significant variability in the type of musculoskeletal exam that is used as part of the PPE. Most of the providers are using a 90-second musculoskeletal screen, which is similar to that general medical screen I showed before. So additional limitations of the PPE. There's significant variation in how the provider's education and the comfort with completing sports physicals. Completion outside of the medical home makes follow-up care and the ability to address abnormal findings very difficult. Additionally, an athlete's condition may change throughout the year, but their medical eligibility will usually not be updated. And so if someone sustains an injury after they got their sports physical, they're not going back to their provider to then change that form. There's also several burdens of the sports physical. There's the burdens to the athletes and their families, providers and the healthcare system, as well as to schools and coaches. The first and most significant burden is time. Obtaining a PPE usually requires taking off school and work for parents. Completion within the medical home may be difficult due to scheduling, especially if an athlete decides at the last minute to participate in a sport. We all know how difficult it is to get into providers sometimes. And so if you decide, oh, I want to play a fall sport and it's 2 days before that sport starts, you might not be able to get it with your medical provider. Additionally, if further evaluation is required, athletes might have to wait a long time and possibly the length of the season to see a specialist. So if you find a murmur or some other cardiac finding that you are hesitant to clear someone for, it might take several months to get in with cardiology. Additionally, these exams cannot always be completed during the well-child check, despite the recommendation for doing so. That's mostly because some states do require that the PPEs are completed during the same academic year as sports participation and have specific dates after which the exam must be completed. For example, Pennsylvania requires that the exam be completed after June 1st. And so for that fall sport. So if you had your well-child check in February of the year previous, you would not be able to count the sports physical during that time for that next fall season or for that next academic year. We're lucky in Chicago that our sports physicals are good for 365 days, so they can be completed anytime within the year and good for that entire next academic year. There's also the financial burden. It's usually an out-of-pocket expense, especially if done separate from the wellness visit. Billing the PPE as a health supervision visit might preclude additional preventative visits for that calendar year. Urgent or acute cares do not usually accept insurance for the sports physical. And in just looking at the cost at some urgent cares, this WellNow urgent care charges $49 for the sports physical. This Midwest Express clinic charges $35, and CVS would charge $69 to complete a sports physical. For providers, it's difficult to find time to incorporate the sports physical into an already packed visit. The survey of ICAP members found that 2% of providers schedule PPEs separate from the well-child check, and 15% allow extra time to visit if the PPE is completed during that well-child visit. Almost half of the providers that complete PPEs during well-child checks report lack of time interfering with proficiency in completing the PPE. Additionally, if a patient decides to participate in a sport after the visit, the pediatrician may have to review the records and sign a form with incomplete data in their own time. So they might not have done a full orthopedic screening exam during that visit, and they might not have had the opportunity to go over the history form with the athlete and their parent, and then they're forced to fill out the sports physical based on whatever information they did have from that well-child check. For schools, it's often a burden to track the sports physical forms and athletes' medical eligibility status. So those states that do require them to be done within the same academic year, the reason is because it helps those schools stay organized with the forms and know who needs to get a renewal of their sports physical form. Most CPS schools will actually accept any form. So If you clear them to play on the school physical, they'll accept that. They'll accept the old IHSA form or the new one, which is proposed by that PPE 5th edition. And just as I mentioned before, discrepancies between the forms leads to a lot of confusion and not knowing if a student athlete can actually be cleared to play or not. So that's why it's really important to stay consistent throughout forms. There's also no system in place to notify the school or students when their sports physical is lapsing. And so some coaches might figure out in the middle of a season that one of their athletes does not have an up-to-date PPE, and then they'll have to stop playing until they get that form completed, which can be a huge burden on that athlete and that school if they're really, banking on that athlete to help their team. There's also a lack of consensus for who is responsible for monitoring the athlete's status reported on the forms. Oftentimes, the less affluent schools are less likely to have an athletic trainer or a team physician that can help review the sports physicals, and so it leaves the responsibility on the coaches or athletic directors. There's several inequalities of the PPEs as well. Children in low-income households are 1/2 as likely to participate regularly in sports compared with children from higher-income households. As we all are probably well aware, regular sports participation results in lower risk of obesity, chronic disease, alcohol and drug use, and criminal activity, and also leads to increased self-esteem. There are growing disparities in physical activity by income, with the percentage of inactive children in households with annual incomes less than $25,000 rising from 24% in 2012 to 33% in 2018. Only about half of adolescents who have access to a medical home with lower rates among minorities or those living in poverty. And as we discussed before, doing the PPE within the medical home is definitely the ideal place. Athletes without the medical home are forced to use the more costly urgent cares for completion of sports physicals, and this might be cost prohibitive. Lower income families with working parents have a harder time taking off work to get the athlete to get a PPE. And then access to the specialty care for patients with public aid causes increased time to clearance if additional evaluation is needed. In this 2014 survey of Washington State High School athletic directors reported financial limitations of the family as the primary obstacle for student athletes obtaining a sports physical. So the consequences of not getting one. There's the inability to participate in most organized sports. There's the missed opportunity to discuss several health topics, including the importance of physical activity. And athletes are not getting screened for conditions that could put them at risk for poor outcomes during sports participation. So in conclusion, is the PPE a beneficial evaluation tool? Well, it does not effectively screen for or prevent morbidity and mortality in sports participation, as we previously discussed. And adolescents from lower income households that would benefit significantly from sports participation may be excluded due to inabilities to get a sports physical. However, it's currently the standard of care and the best tool we have for identifying conditions that potentially place athletes at risk. And it does provide a platform for discussing several topics related to physical activity in sports that are often ignored during the well child checks. My personal recommendation is that all providers that are completing these sports physicals should have access to the PPE monograph for reference. Universal use of this is encouraged to standardize the process across providers. And I also recommend completing a sports physical during every well visit of patients in 8th through 12th grade. For me personally, my adolescents have to convince me they don't need one. And if they're telling me they don't need one, I still use it as an opportunity to discuss the importance of physical activity and to discuss ways that they can be safe during that participation. Elements of the sports physical should be incorporated into all healthcare maintenance visits. So we should be screening all of our patients for cardiac risk factors and musculoskeletal injuries, because we are wanting all of our patients to be active and we want them to all be active in a safe way. So just because they're not participating in an organized sport doesn't mean they're at any less risk of injury or morbidity or mortality during their athletic participation. And then it's really important to make informed decisions regarding the level of participation and the medical eligibility. So if you are restricting someone, try to think of alternatives for them to do in the meantime, or maybe they can go at half speed, or they can do some elements of the sport they want to, but not all of them. And try to think about if, restricting them, would any rehab or medication adjustments or some other control of conditions be able to allow them to play safely? So we got through that really quickly, but we have a lot of time for questions. Trying to start him early with hockey.
Yeah. So is there any research into like if there's a difference in who's conducting these screenings? Like, can a nurse do it just as effectively as a physician?
So, so did you guys all hear that question? I'll repeat it. So he was just asking if different providers can complete these forms, and if so, is there a difference in how they're completing them? Is that?
Yeah.
So different states have different requirements for who can and cannot complete them. Some states allow chiropractors, naturopathic physicians, physical therapists, nurse practitioners. So some states allow kind of anyone to. Some states will say that it has to be a advanced practitioner or physician. And there's so much variation even in between providers of the same kind of discipline. So there's definitely a variation between providers of different disciplines, such as if a chiropractor or MDDO were completing it. And a lot of it has to do with the education that was received during training. And a lot of people, even during residencies, they are not given good guidance on how to complete them. So there have been several studies that looked at doing a sports medicine fellowship versus other forms of primary care, kind of how those variations are. Does that answer it? Yeah.
Regarding patients who come in with a previous concussion, what type of steps do you normally take?
So the first thing would be kind of asking when their concussion was and making sure that they're completely cleared for their concussion. And then I would first off start by saying, that's great that you knew that you had a concussion, and so you know what one is. Let me just go over what a concussion is and make sure you're on the same page. And then I would also discuss kind of what sport they're doing and just say that there is, if it's football or rugby, just make sure they understand there is an increased risk. But there's no number of concussions that would limit them from participation. Everything kind of in medicine in general, and specifically in regards to sports, is that risk benefit kind of relationship, and discussing with parents and the students kind of what those risks are, making sure they understand it. But if someone comes in with a concussion, I just kind of say, great, I want to make sure you're cleared. You know what one is. If it happens again, make sure to sit out and get evaluated. So we have a lot of questions from the room that I'm in. So if anyone else has questions.
Yeah.
I'll get to yours in 1 second, Courtney.
I took it away from you. Sorry.
Okay. For college and sickle cell, okay. For college NCAA athletes, sickle cell trait evaluation screening is suggested for all athletes. Can you comment on this? Yes, it is required, and oftentimes we'll have student athletes that are asking for their newborn screen to kind of show this. And that's because even having sickle cell trait can put you at risk for dehydration, especially if you're doing sports such as football and you're having 2 days in a warm climate. So sickle cell trait is still a risk factor for dehydration, and it's something that it's not really well studied about why, if it makes any difference, kind of knowing this or not. But that's the real reason. There is, most colleges will have a checkbox that says like, I waive my right of, or waive the requirement to know if I have sickle cell trait or not. But it's usually related to just that dehydration at that more extreme level. Okay, yeah.
What do you feel like are the most common things that kids get benched for, like on this, like that they're saying that they're having like chest pain, or like maybe it requires like a workup, but like what are the things that we would most commonly see?
Yeah, so the question was, what do we most commonly see in kids that would make us kind of exclude them or kind of limit for now? Oftentimes it definitely is chest pain, shortness of breath, those like palpitations, and often by reviewing those, so they'll mark it on the history, and then reviewing those questions does often lead to realizing that it's not clinically relevant. One of the great things about that PPE monograph is it has recommendations for secondary questions to all of those primary questions and ways to kind of tease out better, is it really due to a cardiac cause or not? Of course, if there's concern, you always want to err on the side of caution, but oftentimes, you know, with the feeling short of breath, you want to figure out, is it more asthma? Is it deconditioning? Is it really cardiac? And so the PPE monograph gives great guidance on that. Also, things like syncope or near syncope. If they have that during exertion, that's very different than right after they stop. So if they ran a mile, they stop, and then they feel syncopal, that's very different from during my mile, I felt syncopal or I passed out. So trying to read through those. And that one study I showed of comparing that like 14-point evaluation versus the EKG showed that after the physician review, there were far fewer clinically relevant positives. And that's because oftentimes we do get that shorter breath. My heart was racing, and just trying to kind of tease it out.
I was curious if you looked into pre-participation cognitive testing specifically, kind of the usefulness that has.
What?
I remember doing it when I played hockey, but it's kind of like a MOCA-esque, like cognitive function thing. You take it before.
So that's more for concussions.
Yeah.
So it's not recommended for concussions,
Okay.
Because it hasn't really been found to change outcomes, and it doesn't really help. The question for all of those that couldn't hear was asking about any cognitive screening during the sports physical, mostly for concussions. Also, it really is a burden on providers, student athletes, everyone, especially from the less affluent areas that can't afford to get those screenings. But the biggest thing is it hasn't shown any positive benefits for preventing concussions or for providing any guidance on how to kind of recover. And mostly impact testing is the big one that's used.
Do you feel like doing this evaluation and doing any counseling for patients and parents is like reasonably done within like the 20-minute frame that usually is?
Yeah, so one of the, so the question was if this can reasonably done within 20 minutes. So we are very fortunate here that our adolescent visits are 40 minutes now, which makes it so much easier to be able to incorporate this in. I would say with practice, because there is a lot of overlap between the preventative kind of guidance that we're giving during the sports physical and during well-child checks, it's possible, but it's definitely tight. And I think that's one of the biggest issues with it, is that there's just not enough time with regular visits to be doing it. And so that is a really big critique and criticism of this in general, is yeah, there's not enough time. But I think the important thing is always asking about those key things, such as like the cardiac history, musculoskeletal, and then there's other things that you can discuss and screen for, such as like skin disorders like MRSA that could put you at risk for spreading disease. And so there's a lot of other elements to the PPE, but the main things you want to address would be the cardiovascular and the musculoskeletal. And you can just do what you can at the time allowed.
Liz, it's Carrie. Can you hear me?
Yes.
Okay, I'm trying to figure out the box drop and the step drop test. It sounds like both of those require a step.
So those do, and to be honest, I've never done them, and I feel like there's other screenings that are just as effective and don't require a box. And at the end of the day, they don't really tell me much more that's going to help in determining their clearance or providing guidance. I do most of the time use that single leg squat that I showed. That's one of my favorite tests because it really shows a lot about the neuromuscular control, and it doesn't require any other elements, and there's no risk of getting harmed by like jumping off the box incorrectly. So I don't use that drop box test. And also those tests are often only recommended if someone's doing a high agility sport, or if they've maybe had a previous injury and you're trying to test them to see if they're able to get back to sport. But I agree, that box drop test, it does require additional equipment that is not going to be readily available. And there's other tests that can be used to do just the same thing.
And am I correct in assuming that we are no longer care if you've had COVID in the past? I know there was that brief moment in time we were doing all that COVID screening.
Yeah, the most recent recommendations are that it's not really necessary, just like screening for any cardiovascular kind of concern. If there's any concern for ongoing cardiac issues or long COVID, then it is still recommended to get evaluated by cardiology. But just because someone's had COVID does not mean they need additional workup. Something else that's interesting, so on the CPS website, they still have that additional COVID questionnaire listed. However, in speaking with several athletic directors, they weren't even aware that that was a thing, and they don't even look at it. So I have not even been doing that COVID questionnaire because it's not being utilized, and it's not changing anything that I'm doing after I ask for the other cardiac questions.
Okay, great, thanks.
What is the thought process regarding having the PHQ-4 questionnaire?
Yeah.
Is the purpose to find individuals who have anxiety, depression, and to start treating? And then also, how does it impact if you're not presenting this to the school, now the school knows that this individual has a mental health condition?
Yeah, so that aspect of this new form is probably one of the most controversial because mental health, we're now realizing, plays such an important impact in athletes. And so it's really important to ask that. And then also, when this form is being used as the only preventative healthcare that a student athlete might be getting, it's real, like, mental health is so important. So if this is our only access to these student athletes, we got to ask about it. But it definitely makes it very difficult if you get a positive response, especially outside of the medical home, and being able to respond to that. But the thought process is, it's better to ask and know than to not know, and to leave these student athletes like without anyone knowing what they're going through. So it's always better to know, but it's definitely difficult, especially outside of the medical home. But mental health plays such a big role in everyone, and definitely athletes as well.
Yeah.
No, you can.
Does it ever fall on pediatrician? I remember when I was working with a family medicine doctor in med school, and just like as a high school athlete myself, like when you play up, you have to get like testing for like puberty and things, like to see if you can like play on JV or like play on varsity. Like, is there any like evidence behind that?
No, and that's not recommended. And I think certain states were doing that like years ago, but there wasn't really any evidence for it, especially now that we're learning that like athletes of any age, any like puberty standpoint, can lift weights, can do all of that without any harm to their body. So there's absolutely no reason to be.
Yeah, because that was like 4 years. Yeah, it wasn't like that long ago, and I just remember being so. It just seemed so odd that we were like judging these like little kids that just want them to like
Yeah.
basketball.
And that goes back to this whole idea of it's not standardized at all. And a lot of states are using non-evidence-based exams and like not recommended by any of the PPE monographs, and not using any American Heart Association guidelines. And so then it begs to question kind of what is their purpose if the best evidence we have is still not that great at preventing morbidity and mortality. And then a lot of these states are using forms that are very outdated and not based on any clinical evidence. Recently, there was a big survey that went out to the pediatric sports providers, kind of asking about what our states did. And there's a few states or their providers in those states that are trying to fight the PPE in general and say that it should no longer be required just because of all the burdens it places, how it's not very effective, and it's just not very standardized.
Hi, Liz. This is Kathryn. Can you hear me okay?
Yep, great.
First, thanks so much for this. This is really such a great topic. This is so important in clinical practice, and it can keep you up at night, given that this is like trying to find a very small needle in a haystack, and the importance of doing it well. That one study you showed that I think it was somewhere around 11,000 athletes, maybe it was the soccer players, and some of them slipped through the cracks. There was a small number, but they still slipped through the cracks.
I think it was 6, yeah, slipped through the cracks.
Yeah, what should we learn from that? What better things should we do that might catch those other kids?
So I think the biggest takeaway is knowing that we're not going to always be able to catch everyone. The other thing that about that study though is that I didn't mention, the student athletes were only screened once throughout a 6-year period. So the study happened over 6 or 7 years. They were only screened once. So one of the limitations was they did not do annual screenings. One of the questions about the PP is how often it should be done and completed. So by doing this advanced screening every year, it might pick up more, just because as athletes mature, go through puberty, their heart does change. The heart is a muscle. And so there is some suggestion that doing echoes at periodic timeframes through as the adolescent is growing, you might pick up on more of the hypertrophic cardiomyopathy because the 12-year-old heart might be different from their 18-year-old heart. So more frequent screening might have picked up on some of these, but I think the big takeaway is you're not going to be able to pick up on all.
So I guess a follow-up question is, I know that the evidence doesn't seem like it's really there for universal EKG or pre-participation.
Yeah.
But do you see a future for maybe using it in some circumstances, a subset of kids, or what's the future of EKG in this realm?
So I think it's already recommended to be completed if there's any issues or you're concerned at any capacity. You know, basketball players have been found to be the highest risk for positive findings on that EKG. So there has been some discussion of should it be used in especially like NCAA basketball players, but they haven't quite figured out what specific population it should be used in. And the biggest issue is who's going to be reading all these EKGs, because the athlete heart is a little bit different from the non-conditioned heart. And so there's a lot of false positives, which could lead to more restriction. So I think one of the bigger issues is who's reading these and then who's going to pay for the EKGs, because insurance currently will not pay for EKGs as part of the pre-participation physical evaluation. So there's definitely evidence that shows it will pick up on more people than just the current screening we have. However, the cost effectiveness is not currently, does not currently support doing them, even for like a subset, because there's so many questions about what that subset would be. How do you do it without discriminating against certain populations? So if it were only, offered at certain schools that might be more able to afford it or front the cost to help get their students screened, that leaves out a big proportion of maybe less affluent schools that can't do it for their students. So there's no question that it would pick up on more athletes, but it just is not found to be cost effective right now, and they can't figure out how to do it correctly.
Thank you. Thank you.
Hey, Liz, can you hear me? It's Renee.
Yep.
I wanted to know if you could talk about the vision screen and like the current recommendations and evidence, and when they don't screen with good vision, of course we refer them to the eye doctor, but when do we not clear them, or can you comment about that, please?
Yeah, so what was interesting, I'm trying to get back to this one slide, I didn't comment, but so a lot of, in that survey of ICAP providers, actually a significant amount of providers are not doing it even during well child checks. And in terms of, so this last question, how frequently do you include annual visual acuity screening? It was found that it's not commonly done during well child checks or PPEs. Current recommendations are if someone's vision is worse than 20/40, so you do that Snellen chart and their vision's 20/40, I would discuss with them that they need to get glasses, their vision's not good, but I would still clear them. If it is worse than 20/40 in either eye, then I say most likely it's just because of they haven't gotten their eyes checked for a while. And so it definitely, promotes them getting their eyes checked, but oftentimes it's not actually due to some visual impairment. So what I personally will say and what I kind of learned in fellowship is cleared for 30 days from the date of this exam, but then must show proof of best corrected vision 20/40 or better in order to play contact sports. So the recommendation is now, if they cannot show best corrected vision better than that, you're supposed to wear protective goggles so that you can protect the good eye. Everything is discussion of risk benefit. So if they have a bad eye that cannot be corrected to better than 20/40, you don't want to leave them legally blind. So if their good eye were to get hit during a contact sport, and then they're only left with the bad eye. So the biggest thing is them providing protection for that good eye. If they want to participate in a sport that does not allow for any protective eyewear, the recommendation is to not clear them for that sport. But if after a discussion, they're like, I understand the risks and benefits, and they can really do that, then it would be a consideration. There's no like absolute, no, you cannot play. Everything's kind of a discussion. But right now, the recommendation is to not clear someone whose vision cannot be corrected better than 20/40, and they're participating in a sport where they cannot wear corrective eyewear.
And do they get the corrective eyewear? Like, is that like you could buy it where there's sports equipment, or do they need to go to the eye doctor?
Usually the eye doctor is the one that will help get that. So that would, usually be the eye doctor. Any other questions?
Are there any more
Oh, wait.
questions?
One more question back in this room.
Okay.
Can you talk a little bit about how you talk to parents who feel that high school football is unsafe, both in general and specifically with CTE?
Yeah, so, I'll have a conversation and say, it's really, you can, if you decide that it's not what you want your child to be doing, then there's several other sports that they can participate in. If it means a lot to them, and that's like really what the student athlete wants to do, just know every sport has risks to it, and there's definitely benefits to playing a sport that they really love and they enjoy. In terms of concussion, there is a high risk of concussion, but there's also like a high risk in soccer and basketball and other contact sports. So if their biggest concern is concussions, then I say maybe a non-contact sport would be better. But you need to weigh like if that's something they really want to play, or that's the only sport that the school may offer, the benefits might be better. In terms of CTE, high school sports don't really have a big percentage that go on to have CTE. It's more at the higher levels. So I just kind of discussed the risk of concussion in general. And the biggest thing is just knowing when to sit out. So I'll say the biggest thing is just if you do have a concussion, so you get hit in the head, or someone hits you in the chest and your head gets thrown back and you had blurry vision, a little bit of a headache, things just don't feel right, that's a concussion. It's not maybe a concussion, it's a concussion, and you sit out and you need to be evaluated by a provider before you go back in. So I just kind of discussed the risks and benefits.
Hi, it's Renee. I have another question. Can you talk about when I was trained, the AAP frowned on boxing, and maybe there might have also been another sport, I don't remember. Does the AAP still go against boxing, and are there other sports that AAP is against, and how do you manage those when you're having conversations with families?
So right now, in a time when it's challenging to get athletes or students or our patients to be active, I'm generally, I actually don't specifically know the AP stance on boxing, but I personally will say, it's great that they're being active and it's important to wear protective equipment. But as far as I know, there's no sports that the AP strictly says, no, they should not be participating in. And the more there are studies on particular sports or strength training or even marathons, the more they find that there's no evidence supporting restriction from those. So even marathons now, the AP and pediatric sports providers are finding are not necessarily bad for pediatric patients. But the benefit of some sort of physical activity outweighs the risks as long as you discuss those risks.
Okay, you have a question in the chat. It says, hi Liz, can you comment on family cardiac history and your threshold for clearance?
Yeah, so usually if it's in a first degree relative, and to be honest, in a lot of the conditions, I actually have my PPE monograph on hand and I will specifically look it up. And if I have questions, I might, message the cardiologist, because at the end of the day, I'm not a cardiologist. And so if I have any questions, I am going to reference something. There is a lot of guidance out there about specific conditions and what can be cleared. So I actually usually reference the PPE monograph when I am deciding about specific cardiac history. If it's outside of the immediate family, though, I usually err on clearing them, but it depends on the extent of that. Like if it's in everyone in the extended family except, their father, that might be different than only one uncle had a condition. But usually I will actually reference the PPE monograph.
Okay, if there are no more questions, we give you, want to say thank you to Dr. Elizabeth Porton for giving us a very riveting and informational grand rounds today. I want to thank everyone for being here and your participation. Your questions were great. Very good questions. Elizabeth, okay, thank you so much. You guys have a great day.